So my task today is endoscopic management of GI neuroendocrine tumors, and I don't have any disclosures. So this is a 56 years old who was referred to me because of pancreatic cystic lesions incidentally found during the acute abdomen because of acute appendicitis. So while I'm doing the endoscopy, the EUS, I found these lesions. So what are you going to do for these lesions and how to remove it? So this is the objectives. Definitions, epidemiology, characteristic of the neuroendocrine tumor, presentation, clinical syndromes, diagnostic workup, and the management, whether to do it endoscopically or surgically. So neuroendocrine tumors are the second most prevalent cancer of GI tract after colorectal cancer. Over 100,000 patients are living with metastasis neuroendocrine tumor in the United States. The principal care are different completely from the, compared to the solid tumor, the classical solid tumor like colon cancer, for example. So neuroendocrine neoplasm are epithelial neuroplasm arising from the neuroendocrine cells. Neuroendocrine cells are present through the whole GI tract. They can be located in the gastric, duodenal, jejunal, ileal, colon, or rectum. It's better to give them the name by the location of the site rather than giving them foregut or midgut. Also, we have the pancreatic neuroendocrine tumor. The histology is the very important part to differentiate between well-differentiated versus poorly differentiated, and the most important is the proliferation indices, where you have the Ki-67% and the mitotic count. So this is the WHO classifications. Obviously, they classify the neoplasm into well-differentiated and poorly differentiated. You can see that the well-differentiated are, we have G1, G2, and G3, and you can see that the important factor is the mitotic index and the Ki-67 index. The higher the mitotic figure is, the higher the grade of the lesions. And of course, we have the neuroendocrine carcinoma. Now, saying that G3, although it is well differentiated, but you can see the behavior of the G3 is really as if it is carcinoma. Very important to see that we have increasing number of neuroendocrine tumor. You can see that the number is almost 6.4 times increased in the latest years. And you can see that the neuroendocrine tumor is increased not only in the small intestine, the pancreas, and the stomach. And the reason behind this is because we are doing more endoscopy, more gastroscopy, more colonoscopy, and the imaging is started to be increasing. We do more ultrasound, more CT imaging, and that's increased the number dramatically. So very important to see that the classical versus the neuroendocrine tumor size paradigm. So if you see the classical solid tumor, for example, the colon tumor, you can see you will have a huge primary tumor, and then maybe you will have lymph nodes, and then maybe you will have metastasis. So that's, sometimes we do colonoscopy, you see that the tumor is infiltrating, blocking the whole lumen. Nevertheless, the tumor is T3. On the other hand is the neuroendocrine tumor. You can see that you can have small lesions, small tumor, but you have huge lymph node, and maybe the liver is full with metastasis. That is the issues of the neuroendocrine tumor. Adding to that is the heterogeneity of the tumor. You can see that the low burden tumor versus high tumor burden, the resectability, the stable and the progressive nature, the low grade and high grade, the functional and non-functional, and the high expression of serotonin receptors. The presentation of the neuroendocrine tumor are very unique. Majority are incidental finding. When we are doing endoscopy, we see these lesions. And we have also the tumor that cause symptoms, those patients who present with anemia or bleeding. And we have, of course, the hormonal, like insulinoma. The patient will present with symptoms, or those with liver metastasis that they present with Cushing's syndrome, flushing, diarrhea, shortness of breath. General workup, serum chromogranin A is one of the very important tumor markers that we are doing. Unfortunately, it's not so sensitive and non-specific. Nevertheless, we are doing it. The most important part of the chromogranin is the follow-up. if it is raised from the beginning, and then the follow-up is very important, like the CEA for the colon cancer. 24-hour urine 5-hydroxyindolic acid is again very important factor, especially if you have liver metastasis, endoscopy, and biopsy. So it's very important to take deep biopsy because those lesions are from the deep mucosa. So majority of time, if you would take deep biopsy from those lesions, you will have the answer. EUS is very important, especially for the pancreas. We need to do EUS FMB for those lesions in order to have immunohistochemistry to differentiate between the lesions. And also sometimes we need to do the EUS for the staging of the gastric or rectal tumor in order to see if there's any lymph node enlargements. Imaging, CT or MRI, and of course we have the octreoscan scan. And what is more important, nowadays we have the gallium PET scan or DOTA scan, which is really more accurate in the diagnosis and less time and less radiations. So going back to the gastric neuroendocrine, we have 3 types. We have the type 1, type 2, type 3. Type 1 and type 2, more or less, they are the same. You can see that they have small or multiple lesions, mainly in the fundus or body. They have high gastrin level. And the type 1, you have atrophic gastritis, while type 2, you have Zollinger-Ellison syndrome. And you can see that the gastric acid secretion is low in G1, type 1, and high in type 2. And the clinical presentations, usually asymptomatic in type 1, while type 2, they present because of the high acid secretions. They can have reflux esophagitis, peptic ulcer disease, and the histological differentiation is well differentiated, and those small lesions, they can be resected endoscopically. Type 3, usually it behaves like similar to gastric adenocarcinoma. Usually it's single, and usually it is more than 2 centimeters. So this is 42 years old who was referred because of these lesions. You can see the biopsy was turned to be neuroendocrine tumor. And this is the EOS. You can see it is originating from the deep mucosa, and the muscularis propria is completely free. For these patients, we adopted to do EMR. So we are lifting the lesions and then resecting it with the snare. And this, the resected margin was completely free from the lesion. So it's very important to lift it nicely, especially if the tumor is more than 1.5 centimeter. And you can see now we are doing the snare. It's very important to take safety margin in order to have a wide range of resectability, and then snaring. So EOS is very important, especially if the lesion is more than 1 centimeter, in order to see if there is any involvement to the muscularis propria. Then you can see that we didn't have any bleeding after resection of this lesion. Okay, now it's cutting. Okay, now you can see the lesion is completely removed. And here is the lesion. You can see it's completely removed. So if you have gastric type 1, if it is less than 1 centimeter G1, G2, then you can remove it with ESD, which is better slightly than the EMR, or you can do full thickness resections. If the lesions biopsy turn to be G3, then you need to do EUS, and then if there's no any lymph node and there is no any involvement to the muscle, you can also try to do it with ESD or full thickness. If the tumor is between 1 centimeter, 2 centimeter G1 or G2, EUS again for further assessment. If it's more than 2 centimeters, then you need to do wedge resections or gastrectomy with nodal resection. Type 3 is a little bit more aggressive. You need to do staging for those patients with imaging, and then if it is less than 2 centimeter, EUS, and then further assessment, whether if it's small, less than 1 centimeter G1, EMR or ESD. If it is 1 centimeter, 2 centimeter, then wedge resection. So this is the case that we did it recently. You can see this is the lesions. Very important that majority of time when you are seeing those lesions, you can see that this is neuroendocrine tumor. Usually they are harder than the lipoma. You need not to mix it with the lipoma because lipoma is usually soft. So marking of this lesion, for this lesion we adopted to take it with full thickness. You can see we are doing the markers. Very important to do the markers because when you are pulling the lesion to the cap, to make sure that all the lesion have been sucked in the cap. So this is the grasper, and you can see that we are holding the lesion and pulling it inside the cap, and then taking it inside completely. And the marker is very important to be seen during the pulling up the lesions. And then this is the cap, you can see, and once you deploy the stent, this cap will disappear, and that's, you can see that it's disappeared now, and then you will ask your technician to do the snaring, and now he is doing the snare, and this is the final picture after the resection. This is the lesion. You can see the whole tumor have been resected, and this is the histopathology. You can see the safety margin of the full thickness is very beautiful. Because of time, I will leave this. So duodenal neuroendocrine tumor, usually small, arise from D1 and D2. Different types, gastrinoma, non-functional, or somatostatinoma. And the differential diagnosis, you have to keep it in your mind, whether they are adenoma or adenocarcinoma. Just imaging and EUS is very, very important. So if you have duodenal neuroendocrine tumor, the situation is quite different. If you have less than 5 millimeter, you need to do endoscopic resection, snare polypectomy. If it is 5 to 10, you need to do EUS for further assessment. If it is more than 10 mm, you need to go for surgery. So jejunal and ileal neuroendocrine tumor, most small bowel neuroendocrine located at the terminal ileum, 60 centimeters from the ileocecal valve. Usually they present with abdominal pain, bowel obstruction, ischemia, and synchronous tumor are usually can be seen up to 25%. And the treatment is bowel resection with lymphadenectomy, regardless of the tumor size. So this is one of my patients. You can see that this is the cecum. Some nodularity. This patient who was referred because of stool occult blood positive with abdominal pain, and you can see this is the cecum. You can see some nodularity of the cecum, and this is because of eosinophilic colitis, but that's not the issues. So when we entered to the terminal ileum, you can see there was a lesion that we saw it, and very important. Try to go deeper to the in the terminal ileum whenever you go, and you can see this is the lesions, and this turned to be a neuroendocrine tumor. So this is the tumor, you can see, and this patient had been sent for surgery, and he had a resection. So appendiceal neuroendocrine tumor, usually seen during the appendicectomy. If they are in the mid or the tip, usually simple appendicectomy is enough, but if they are in the base or more than 2 centimeters, then the surgeon should go for right hemicolectomy. Colonic neuroendocrine tumor is really very, very rare. If you will remove the rectal, they are less than 8% from the overall neuroendocrine tumor. Most common in the cecum and ascending colon. Mean size during the diagnosis is 5 centimeters. Metastasis is 30%. The patient can present with diarrhea, abdominal pain. Treatment is colonic resection and lymphadenectomy, and the overall 5-year survival is 50%. So this is one of our patients, again referred because of rectal neuroendocrine tumor. You can see the rectal neuroendocrine, usually you can see the yellow discoloration and the central nibbing inside. And this is the EUS of this lesion. You can see it was very related to the muscularis, to the submucosa, and there is no any lymph nodes. There is increasing incidence in the rectal neuroendocrine tumor. Most are small, less than 1 centimeter. Very important to differentiate between T1 and T2. Tumor invades, T1 is the tumor that invades the lamina propria or the submucosa or less than 2 centimeters. and T2 is the invades to the muscularis propria and more than 2 centimeters. Very important to see that the size correlates to the metastasis. If the lesion is less than 1 centimeter, the metastasis is less than 2%. If the lesion is 1 to 2 centimeters, up to 15% you can have metastasis. And if the tumor is more than 2 centimeters, you can have up to 80% metastasis. So this is the European neuroendocrine guidelines for rectal neuroendocrine tumor. You can see less than 1 centimeter, you can go for endoscopic resection. If it is 1 to 2, you need to do proper imaging for those cases, ultrasound, MRI, in order to see if there's any lymph node. And then you might go for endoscopic resection. And if they are more than 2 centimeters, you need to go for surgery. So this is the patient. You can see the EUS, as I said. And here is the resections. For this patient, again, we removed it with the EMR after lifting. You can see we use the blue eye to lift the lesion nicely. And again, very important to push your snare, suck it, and take safety margin in order to remove it in a very complete way. And this lesion also tends to be completely resected from the margin.
Very nice, Khalid.
Okay.
Yes.
So you can see that the final cutting of the lesions. So this is the cutting. It was nice. So, ladies and gentlemen, this is the conclusions. Neuroendocrine neoplasm include neuroendocrine neoplasm or neuroendocrine carcinoma. A neuroendocrine tumor are well differentiated, categorizing to G1, G2, and G3. And the GI neuroendocrine present incidentally or maybe with complication because of bleeding, or maybe if there is any hormonal secretion like insulinoma. Management depends on the location, the size, the histology, and the stage of the lesions. Small gastric or duodenal neuroendocrine tumor less than 1 centimeter can be resected endoscopically. Jejunal, ileal, intestinal resection with lymph node resections. Appendiceal neuroendocrine simple appendicectomy, or if it is more than 2 centimeter, right hemicolectomy. Colonic neuroendocrine, usually they present late resections with lymphadenectomy. And most rectal neuroendocrine tumor are less than 1 centimeter, and endoscopic resection with no follow-up if complete resections, or if they are more than 2 centimeters, then you need to do to send the patient for surgery. Thank you.